Welcome to this Onc Live News Network presentation, broadcasting live from MGH Studios. Today's discussion will be focused on treatment of HER2-positive early breast cancer, with a focus on recent data and how to incorporate them into treatment planning. I'm your host, Dr. Adam Brusky, Professor of Medicine and Associate Chief of Hematology Oncology at the University of Pittsburgh School of Medicine in Pittsburgh, Pennsylvania. Today I'm joined by three of my colleagues who are renowned experts in the field. Kim Blackwell, Professor of Medicine and Co-Director of the Women's Cancer Program at Duke Cancer Institute in Durham, North Carolina. Hope Rugo, Professor of Medicine and Director of Breast Oncology and Clinical Trial Education at the UCSF Helen Diller Family Comprehensive Breast Cancer Center at San Francisco, California. And finally, Dr. Lee Schwartzberg, Executive Director of the West Cancer Center, Professor of Medicine and Chief of the Division of Hematology Oncology at the University of Tennessee Health Science Center in Memphis, Tennessee. During the next 60 minutes, we are going to talk about some of the questions surrounding adjuvant treatment of HER2-positive early-stage breast cancer and how our expert panelists interpret the available data. During the last few minutes of this broadcast, we will answer questions that were submitted from the audience in advance. So now let's start, I think, with one of the successes of our business so far. I mean, clearly trastuzumab has changed the way we treat metastatic disease, and honestly, I think it's changed the way we treat neoadjuvant early-stage breast cancer. And let's start kind of, Kim, where are you now with Neosphere, with Trifania, and these sort of trials? I mean, how do you treat HER2-positive early-stage breast cancer based on some of this data?
Yeah, well, I think my practice is consistent with many that when we are first seeing a patient facing HER2-positive early-stage breast cancer, we try to get their treatment in preoperatively in the neoadjuvant setting. And lucky for us, we have a number of trials that have looked at the incorporation of HER2 targeting agents such as pertuzumab and trastuzumab in the preoperative setting, two of which you've mentioned, the Neosphere study, which actually led or contributed to the accelerated approval of pertuzumab, and the Trifina study that really all the patients got pertuzumab, and it was really more of a safety study looking at different combinations with pertuzumab. So we have good studies that demonstrate a high level of activity, meaning a high level of complete pathologic response rate when we incorporate tras, pertuzumab, and chemo. And then we have adjuvant studies that really look at, do you need an anthracycline, in particular, looking at different formulations of, not formulations, but combinations of adriamycin, taxane, trastuzumab, or a non-anthracycline combination. And those have really shown that, at least with 10 years of follow-up in one of those studies, there's no real benefit to giving an anthracycline in the post-operative setting. So I use the post-operative data that says an anthracycline probably doesn't contribute that much on top of a HER2-directed backbone. I take the safety data from the preoperative studies, and my regimen, at least for most patients, unless they have a very small tumor and a need for preoperative therapy, is a TCHP kind of regimen. So Docetaxel, carboplatin, trastuzumab, and pertuzumab for 6 cycles.
And you don't add AC to that at all, or FEC or whatever?
Well, the thing I really, I think is very clinically useful is this idea that you give 6 cycles of preoperative therapy. And I'm constantly telling my fellows that if you really have a HER2-addicted tumor, those tumors, for all practical purposes, melt away. Occasionally, you'll see a very strongly ER-positive with maybe a low proliferation rate and perhaps a low HER2 FISH ratio that won't melt away. But if you truly have a HER2-addicted tumor, they melt away. So in those patients that have a high residual disease burden, meaning you give TCHP, you take them to surgery, especially if they still have cancer within their lymph nodes, I will consider an anthracycline. I have several patients that unfortunately recently had a fair amount. I always restain the residual tumor because that sometimes will give you some helpful hints as to why their tumors didn't melt away. And I think it's very reasonable to consider adding an anthracycline post-operatively or even preoperatively if you don't see the response to 6 cycles of TCHP. We know that having no cancer in the lymph nodes of the axil at the time of surgery is a very important long-term prognostic marker.
So do you agree, Lee? I mean, what do you guys do there?
Our practice is split about 50-50 between TCHP in neoadjuvant and ACTHP. And I do think that TCHP is a very effective regimen. But there is a fair amount of toxicity, and if we've seen more data now, we've seen that the grade 3 toxicity is reasonable and is reasonably high. And some patients actually do fine with AC, with sequential therapy. So AC followed by either weekly Paclitaxel and pertuzumab and trastuzumab, or Docetaxel for 4 cycles, as was done in both of the other and neoadjuvant studies, I think also works. Now, I tend to restrict that to younger patients who don't have cardiac risk factors like hypertension and longstanding diabetes or any cardiac disease. I'm also still a little concerned not only about the patients that Kim talked about, which are the low proliferative patients, but also some of the patients who are HER2 highly proliferative, especially large tumors that could be somewhat heterogeneous and have some areas where HER2 may not be as effective. And there, I think the dose-dense approach with an anthracycline might take care of those patients. And then finally, we have, in the adjuvant setting, we don't have any studies that show non-anthracyclines are better. I mean, certainly in BCRG-006 it was close, but even there it was a little bit less, a couple % less in terms of disease-free survival. So I think either is fine. I don't think there's one superior, but I do always give it in the in preoperative setting. So I don't do pre and then post. I think it's difficult to wait. Patients also want to get finished with their chemotherapy.
And I'll say that what drives your avoidance of anthracycline in the older patient population also drives my avoidance of anthracycline in the younger, because when I sit down and have this discussion, obviously my older patients are concerned about the risk for cardiac toxicity, but I'm also facing a lot of younger women not wanting to have that risk as well.
Well, I think that, we have good data suggesting that there isn't late cardiac toxicity from anthracyclines. Radiation a little bit different, but from anthracyclines. And it's interesting. I mean, since we've started using pertuzumab, routinely in the neoadjuvant setting, TCHP has become a much more toxic regimen, because some people get really very severe diarrhea that's hard to control, and it really kind of ruins their life. And I guess I wouldn't like to give the full 6 cycles of TCHP if they weren't responding, and then go on to an anthracycline. And I also try really hard to give the chemo for HER2-positive disease preoperatively if we can. I like the idea of trying to triage how much treatment you give based on response, where you would potentially give a Paclitaxel, trastuzumab, pertuzumab approach, and try to see if, in the very HER2-addicted tumors, you may not need the carboplatin at all. Certainly in the metastatic setting, it wasn't necessary, and it increased toxicity. So, I mean, obviously we're dealing with the regimens we have, right?
Well, and the way they were designed, remember, TCH was designed before the TCH-TH data came out in metastatic disease, right?
Yeah.
So we're kind of victims of the clinical trial design.
Right. But when you looked at the addition of carboplatin in the first-line metastatic setting, it didn't
do anything.
And so I wonder if, with the addition of pertuzumab, whether or not we really need the carboplatin, but that's a whole other question.
Well,
so
but there's data from San Antonio this year, right? On that, somebody analyzed
a
it.
retrospective analysis of the very large MD Anderson database suggested that people had just as high PCR rates with Paclitaxel-based regimen. So one of the things that we've been doing more of is Paclitaxel, trastuzumab, pertuzumab in these older patients where I can't give TCHP easily. And if they have a great response, then you're done. You don't have to go on to the more intensive regimen. And for our younger patients, we have used largely an anthracycline-based regimen, but with a weekly Paclitaxel, trastuzumab, pertuzumab. But again, I think that right now we're in a time where we're really trying to figure out how to do less in patients who have very responsive tumors, and then figuring out what the right more is, which I don't think we know yet, because we don't have really biomarkers to tell us what the right additional therapy is. And maybe some of the newer agents, the ADCs, et cetera, will be the right newer agents.
Yeah, I will say that I'm impressed in a not so good way with the amount of diarrhea you do see with TCHP.
Right.
And what's, my own kind of clinical experience is you end up having to drop out the pertuzumab because of the diarrhea. And then what's interesting to me is it's that combination of steroids and the TCH, but then out back, I've been reintroducing the pertuzumab, and most patients actually tolerate it much better when it's given outside. So I don't know if I'm doing the right
Not with
thing.
chemo.
Without chemo.
Without
Yeah.
chemo, yeah. And so
I know, I have
I-
more of a tendency to drop the carbo.
There's
and
no
keep the
reason to think,
pertuzumab.
I mean, if you
I
think about
dropped
it,
the
it's
carbo
not-
as
Yeah.
well. Yeah.
I
So
figured
you drop the
carbo
carbo
is
early,
less.
so someone will come in and get TCHP,
Right.
they'll get sick with the carbo, you'll drop the carbo. So now
Right.
you're on THP, and you continue that?
Yes.
And
I
then you
would
don't have
continue
to
that for
worry
6
about their
cycles.
platelets either.
sick with
Correct.
diarrhea, you
Yeah,
mean?
yeah,
Yeah.
sick with diarrhea. And if they get admitted to the hospital, which does even now
Correct.
occasionally happen, despite our best efforts at
Right.
prophylaxis, then I would drop
Right.
it.
The other thing that's interesting about 6 cycles of a T regimen with docetaxel is that once you get up to 400 or so milligrams per meter squared of docetaxel, you have an increased risk of poor hair regrowth and a small number of patients who appear to have never actually recover their hair. But some people, we've all seen it, 2 years and they're waiting to get their full head of hair. So maybe with scalp cooling we'll be able to avoid that. That remains to be seen. But I think that also certainly impacts my use of that regimen in young patients, and then it causes more permanent ovarian suppression as well. So, you have a few things we're balancing against, the toxicity of anthracyclines versus the toxicity of that
You mean
regimen.
Docetaxel C causes more?
No, TCH
causes more
regardless
ovarian
of the P.
suppression.
The P and H don't matter.
Right, so
T-
T for
T
6
carbo.
cycles causes more ovarian suppression
Permanent.
permanent than
suppression.
Docetaxel C for 4, is what
Yes.
you're saying. Because it's the C, not really the A, right, for the
Yeah.
ovaries?
It's the same.
It's the C.
No, I mean, there's clearly higher numbers, and I think, obviously it depends on the age of the patient and how much ovarian reserve they have, and, we all try and harvest eggs or freeze embryos beforehand, but that's a whole nother issue in and of itself. So.
Right.
Yeah, and I'm actually using a fair amount of Paclitaxel, trastuzumab, pertuzumab, so it makes me happy to hear you saying that
In the
you're using
neoadjuvant
it.
setting.
The preoperative setting, in particular, the younger woman that maybe premature ovarian failure is a concern. Maybe she comes in with a 2 centimeter ER-positive breast cancer, obviously, and HER2-driven. I'm going to give her the HER2 agents, but I really want to spare her the toxicity of the carboplatin, the potential cardiac toxicity of the anthracycline, and I've been very impressed with the activity of that.
Enormous.
Yes,
So
I-
you'll
I
just,
think-
how will you give that regimen?
12 weeks of Paclitaxel, see them at week 7, make certain that the neuropathy is not causing, that's just how I give weekly Paclitaxel in general, and then trastuzumab and pertuzumab at standard doses.
And so therefore you'll give that, so you'll give that for 12 weeks, or 12 weeks? For neoadjuvant,
Correct.
not 16,
No,
not
12.
18.
No.
Well,
So then why
it's
are we
based
giving,
on
so
the,
why are we giving, so it's based on what?
well, it's based on the APT trial, so it's the extrapolation of the APT
To the
trial.
neoadjuvant setting.
To the
not
neoadjuvant
adjuvant
setting.
And we've done it actually quite a lot. We had a woman in her 70s with severe scoliosis and, she's like hunched over and not great medical care. And, I don't know how her heart was ever evaluated, but, and hypertension, which she'd never treated. This is the kind of patient you're going, ugh. And she has an ER-negative, HER2-positive disease with bulky adenopathy and a big tumor. So I actually just gave her THP and she had no cancer after 12 weeks. And then, of course, she went to surgery and dropped her ejection fraction. She had a path CR. I stopped her HER2 targeted therapy too because her EF was like, I don't know, 38%. So it's recovered. But I think that, in that situation, we can actually limit the amount of treatment we're giving patients.
Yeah, and I agree. I treated a 93-year-old with
That's very
Paclitaxel,
impressive.
trastuzumab, and pertuzumab because she came in with a swollen arm, no
I saw
metastatic
that.
She was a good
disease.
93.
It's a good 93.
She was fragile
I
93.
treat
Fragile
80s and
93.
Yeah, and she had
89-year-olds as well.
Bulky
Yeah.
axillary
Well, you have no
adenopathy. She
choice.
was
Yeah.
symptomatic, and we treated her. And the thing is, as her tumor melted away, we got through 12 weeks. And I said, okay, do you want a lumpectomy? And and she's like, no, I'm never having surgery again. I'm 93. And she's still on her pertuzumab, trastuzumab, doing just fine
So
without
to
surgery or
change the subject
radiation.
slightly, I'm just curious what you guys think about this. So you know the trial, I guess it's the Surgeons Alliance, I don't know who's doing this trial. The exceptional responders, you don't do surgery. Are you familiar with that study? Yeah. You know what study I'm talking about, right?
I don't
There's a
know.
trial right now, it's sponsored by one of the surgical groups, I believe, where if someone has, looks like a PCR on MRI, they do not get surgery. Would you accrue to that study?
Yeah, I think in our patient population, it would be difficult. I mean, people would want to be able to choose, their surgery or
Right,
not.
that's
and-
the issue, you want to choose. You can't be
so-
randomized.
Our surgeons have bought into that. At our tumor board yesterday, they said, surgery is going to be a thing in the past.
They're probably right. It's
yeah.
a systemic disease.
Yeah.
Right.
Except for ER-positive breast cancer.
Right, but we'll get to
yeah.
that in a sec. So, I mean,
So-
what I'm hearing, though, is that most of us would give pertuzumab and trastuzumab for at least 6 cycles,
4
or
to
4 to 6 cycles.
Four, yeah.
4 cycles.
The taxane could be docetaxel or docetaxel carboplatin. It could be weekly paclitaxel with HP, even though there's very little data in the neoadjuvant setting for that combination. A lot of us are extrapolating to go further.
And you know, the regimen includes AC on the other end, so if somebody doesn't have a great response, I'll do the AC before the surgery. I'm not going to do
Right,
surgery
and so the
first.
real issue that I think that still divides us and probably divides the country is, and the world, since we're speaking to the world,
One of many issues.
one of
yeah.
many issues, but but this is a breast cancer issue, let's keep it on topic, please. So, you know, the issue is do you add anthracycline to that or not? And I think that, you know, even though you're from the West Coast kind of
That's the
thought-
south part.
That's the south part, the southwest coast, and a lot of the center of the country does not believe in anthracyclines, and both coasts tend to believe in it, I think. Would you agree with that? Tends to be
Right, I trained at Sloan Kettering, and I'm in the middle of the country, which is why we're 50-50.
Right, exactly, and that's the key. So that's the first question. This next question kind of related to this. I think a lot of people want to know the answer to this. So the whole concept of getting TCHP approved in the neoadjuvant setting was this concept of PCR. And obviously PCR was theoretically, and I use theoretically because we're going to talk about the data in a minute, theoretically a reason. It's a surrogate endpoint for disease-free survival. And so are we seeing that in the trials? Do you think we have enough data to say that PCR is definitely a surrogate endpoint for disease-free survival?
We actually have really nice data that Doug Yee presented on behalf of the I-SPY 2 investigators of our, you know, large number of patients who've been through surgery and had a 3 years median follow-up. And you know, it's very, very tightly associated. And I think that when we have the detailed data on RCB or residual cancer burden, that we're going to see that as well with even more granularity. But I believe, you know, there's been a couple of recent publications that have suggested that by giving neoadjuvant chemotherapy, you're actually causing the development of a resistant clone, and that if you just took them to surgery, that wouldn't happen. And I think it's a very, we've written lots of rebuttals and as of others.
Where did that
I
come
think,
from?
I think, you know, because people are in some ways extrapolating from a number of different data sets where people who have residual disease at the time of surgery have a worse outcome, right? So then if you kind of go backwards, you could say, oh, well, you're generating that resistance by giving treatment. But what you're doing is separating the wheat from the chaff, really. What you're doing is saying, you know, by treatment, I'm getting rid of these HER2 addicted clones or whatever it is, your triple negative disease that's very chemotherapy sensitive, and you do end up with a more resistant group of cells, but that cells is going to be there whether you did surgery or not. So I think that, you know, I personally am a true believer that PCR is an excellent indication of outcome. Some people will recur, but very few.
I mean, we have we have B18, we have B27 in the pre-trastuzumab days that shows basically no difference between early or late. How can people make that statement? That's counter to
I
the
think
data
the
that we
point
have.
for the audience, though, is really that PCR is an excellent biomarker.
Tremendous biomarker.
As a
Agreed.
surrogate marker for event-free survival.
Agreed.
We have a meta-analysis that Cortazar done the FDA first. We've got the I-SPY data and many other sets that show all the same thing. So increasingly solid data that if you get a PCR, those patients, the large majority, and particularly in the HER2 subset that we're talking about today, have greater than 90% disease-free survival at 10 years.
So the next question, kind of a related question to this, is who should get it? Who's truly HER2 positive? That's a question that we've been debated for many years. It's kind of sad, but in a way, you know, HER2 was biomarker what, 1995, 1996? Here we are 20 years later, and we're still questioning its value. You know, so the question is,
No, we believe it's value.
well, it's value, but what
questioning
is
its
truly
measurement.
What is a
we're
true
still
measurement
questioning how
of
to
trastuzumab sensitivity? Put it that way. Should we be using a PAM50, like a multi-parametric assay? Should we be using, don't get me started.
Oh my goodness, okay.
I'm being provocative. I don't know the answer. So the thing is, should we use that? Should we use ratio? Should we use
Well, we have
copy
guidelines
number?
which tell
What should
us
we
what
do?
to do.
Yeah, we do, but the guidelines, you know, if everybody has a pathologist like Mike Press, and very few of us do, those guidelines are great. So what do we do? You know, how do
Email
we
him
handle
when you
this?
have a question. I'm joking. But
Well, I think, first of all, the guidelines are very good, and they've gotten more and more rigorous over time. So
Right.
we know that if you have an IHC of 3, and that to a certain extent is in the eye of the beholder, and we review pathology. Sometimes the 2s that come in get turned into a 1 or a 3.
Right.
So you have to have a good pathologist who
Correct,
knows
that's
how
very
to do
key.
that. And if you do FISH, which most people will certainly always reflex to, and some people have replaced IHC with FISH, then we know about not only the ratio, but the problem with FISH is that many breast cancer cells, particularly HER2 cells, are aneuploid. So when you do the ratio, sometimes you get varying results. So it's not only about the ratio of greater than 2.
Or
it's about
hyperdiploid, or hyperploid.
Yeah,
Right.
triplet.
Right.
Yeah, so you have to look at the total number of copies. And you're also comparing it to one marker, which is the centromere, and there are other markers to use as well. So a good pathologist will know these things, should know these things in order to test patients.
So, I mean, we're all aware of the data that was just presented at San Antonio from B47 with these HER2 lows that are defined as a ratio less than 2 or 2 plus 1 plus, and they had no benefit from adjuvant trastuzumab. First of all, Kim, do you believe that trial?
Do I believe the results of the
Yes.
trial? Yes. I have looked at those lines and both
And you can't separate.
Yeah, I mean, it's
Can't
really,
separate. Good.
when
Okay, I
I
wanted to be sure of
came
that.
home and showed it to the fellows, I said, there are 2 lines here. So, and you know what? That trial really restored my faith that we need to work harder to find biomarkers besides HER2. Because, you know, if that study had been positive, and meaning that Herceptin benefited patients that don't meet the ASCO guidelines, CAP guidelines, then that would have rocked my entire world. I mean, it would have been good for the patients facing non-HER2 positive breast cancer, but when you think about that, it not only restored my hope, and we need to work harder to find biomarkers, but when we think about what's going on in the immuno-oncology space and some other spaces, it made me really want to work even harder to find that biomarker that helps me understand who needs a certain treatment and who doesn't.
We keep saying that we're moving on, past the one-size-fits-all trials, but I think the frustrating thing about this trial, which, is important in terms of what it told people, because I think there was a lot of questions out in the community in particular about who should receive trastuzumab or not. We would see people who really didn't meet what I think is criteria for HER2-positive disease who received trastuzumab, as well as sequential HER2-targeted therapies. But to do a very large trial, 3,000 to 4,000 patients, without any biomarkers that tell us who's more likely to do worse or better or benefit or not, is hard. And it's a balance between not having the biomarkers yet, but needing the drug development to keep moving forward because of patent life and all sorts of other issues. So I think that's one of the toughest things we face, actually.
Negative trials are helpful.
They are, and this is a helpful one.
They prove that this concept is important, but also HER2, as we measured by either IHC or FISH, is not a perfect biomarker because we're not looking at the signaling. And there are a number of diagnostic companies looking at that. There are other ways to approach signaling of HER2 once you've turned on in a HER2 addicted.
But you're going to have to do it on a huge sample set of patients, et cetera. So the next question really, I think people are very interested in, how long do you give adjuvant trastuzumab? So in other words, you have the neoadjuvant, all of us agree with a certain size tumor. I think we're coalescing around T2, but maybe we could talk a little bit more about that in a few minutes. So, but the real issue, so you've given the pertuzumab, trastuzumab, whatever chemo combination. How long do you give adjuvant trastuzumab? We have the SOL trial. Are you sold on the SOL trial?
Am I sold on that? No, and I give a year.
Okay.
So I think there's enough.
The SOL trial, by the way, is 9 weeks versus a year of trastuzumab.
Sorry,
by the
and
way.
we have
presented at San Antonio.
I can't remember the name of the trial. We have 6 months versus a year.
That was the French trial. FAIR, I think.
FAIR
Yeah.
and short HER and SOLD. All 3 showed non-inferiority. They didn't meet the non-inferiority
Interval.
endpoint.
Well, that's a big thing, isn't it? You don't meet the endpoint. So, but anyway, but everybody seems to have a different opinion. I mean, you are of the opinion that some people could get
A shorter
9 weeks
course.
or 12 weeks versus a year.
Well, I think that what's really important about those studies is, first, that in the U.S., where we already were giving people a year of trastuzumab, and in the metastatic setting giving it forever, we still are giving a year. So it supports what we're doing already. And HERA supported not going to 2 years. And we have alternate therapies to extend our adjuvant therapy with. But in many countries, people can't get any trastuzumab, or they get a very short amount. And what I think we have from the accumulated data from those 3, really from 2 of those studies, is that intensive chemotherapy may be able to overcome some of the additional value of extending trastuzumab. So 100 per meter squared of docetaxel there didn't seem to be as big a difference between 9 weeks and 12 months, or any difference, versus 75 per meter squared, but it's more toxic. And then the second thing is that very low risk tumors that are HER2 positive may do just as well with 9 weeks versus 12 months. So that's really helpful for people who can't access a full year of trastuzumab.
Okay.
Yeah, and the other thing I just want to add to what Hope said is that there are patients who you get 6 months down the road on their tras and they drop their EF.
Right.
I've had one patient who literally just had perceived or real side effects from it, and at least I don't feel super compelled to say you have to do this. So I think that gives you a little bit of leeway in terms of, if there is a problem, which is pretty rare, but if it was a problem, then I had a patient who actually lost insurance coverage, and I think she had like 14 doses.
Right.
And I mean, we worked with the patient assistance program and everything, but she had this big gap of like 12 weeks. And I had one patient who wanted to move to Antarctica when it was summer in Antarctica. And so, and I'm sure Hope would have probably figured out how to get it to Antarctica, but I was like,
Sub-Q therapy.
Yeah, we'll just stop. You've had 15 doses,
You're good enough.
You're good enough.
It's good
Yeah.
enough. And I think that is a message that particularly the audience should hear, and
Right.
that's what those studies help me with.
So the next question is kind of moving on, because we have a lot of topics to cover in a short amount of time, are there anybody who should not get? Let's push it. So the first thing is, are there people, who should just get adjuvant therapy and not neoadjuvant? So who comes in the door who should just get adjuvant therapy?
Well, I think
Who
if you
would
have,
just get adjuvant, not
so
neoadjuvant
the
therapy?
question that comes up frequently in our tumor board is the small T1 HER2 positive tumor and what to do with that. So we always come down to the issue of should we do a sentinel beforehand, and we typically do them after now. So we do in this case because that's the one case where I need the information if I want to use more than 12 weeks of Paclitaxel and trastuzumab, because that's what I'll do. That would be my standard. I know I'm jumping ahead a little bit.
No,
But
that's
let's
fine.
say
This is
you had a
reasonable.
person, and whether they have a positive node or not, as we've been discussing, and you gave them THP for 12 weeks,
Right.
and you go to surgery and there's no cancer. Did it matter to you if she had a positive node originally?
No, if I give THP, but then that's adding the expense of another drug and a little bit more toxicity. So
And-
certainly that's a reasonable option.
You have that neoadjuvant thing. The issue is that someone comes in with, say, a T1C, 1.5 centimeter tumor, strongly ERPR positive, HER2 3+, clinically node negative. What are you going to do with that patient? You going to do surgery on her first?
See, I love to do neoadjuvant therapy. To me, if I'm going to give the APT regimen, I might as well give it before and know how it
Reasonable,
works. But
reasonable.
So the thing that drives my decision making, not just about the nodes, because I think the patient you just described, I was going to give 12 weeks of Paclitaxel and HER2-based therapy.
Neoadjuvantly or adjuvantly?
It doesn't, that's what I'm
Doesn't matter.
addressing.
Okay,
So, but I think we sometimes forget the role of nodal involvement in local regional planning decisions. And I've seen a couple patients who got, their treatment initiated outside and then come to see me, and they're usually like, they've already had half of their TCHP, and they, there was an ultrasound, or sometimes even worse, like a PET scan that showed a hot node that wasn't biopsied.
one of them then moved to my practice.
But it-
actually.
Oh, yeah, and then, yes, I
Seriously.
know, and yeah,
But
she
if
is
they,
serious.
If they get a PCR, does it matter? We don't have the
Well,
answer to that question.
We
and
don't,
we need
and
B51.
so
So.
I think
Yeah.
we need
Yeah.
to be
Right.
honest with these
Yeah.
patients that nodal involvement does drive the standard of care for radiation, especially post-mastectomy radiation therapy, and I don't think in the absence of some of the ongoing clinical trials, I think we have to be a little
It probably
cautious.
doesn't matter that you have a few cells there. I mean, if you do an ultrasound and you do an FNA and you know if a node is involved or not, I can't see doing a sentinel node beforehand. I just don't see that that's going to provide additional benefit.
So speaking of additional benefit, let's move on now, okay, to adding. We've talked about subtracting. And so now the question is, for the last probably 20 minutes of this discussion before we start taking questions, adding. And the first thing that we think about adding is pertuzumab. So we all have talked about neoadjuvant therapy. And the way I look at this is that you're going to get 4 to 6 week cycles, whatever that is, of neoadjuvant pertuzumab. And all we're doing is adding another 13 to 11 pertuzumabs. Do you do that routinely?
I do.
Now, based on the affinity data?
After neoadjuvant?
Yeah,
I do if they don't have a PCR.
you do.
Yes, but if they do have a PCR, I continue trastuzumab alone,
Alone.
for the year.
Kim?
I do it even in the PCR
You do?
patients, because my thinking is that they're highly responsive to HER2-based therapy, and there's a lot of data that would suggest the doublet of antibodies is good. I don't think we have the answer, but I would continue it.
Hope?
I don't know that we have an answer to it either. I have thought recently that, depending on how the patient tolerates it, a number of issues, if you have a pathologic complete response, it may not make sense to continue the pertuzumab. We had really good outcome in patients who have very responsive disease with trastuzumab. So potentially you could stop, and there is some GI toxicity that's ongoing during the course of pertuzumab, trastuzumab. So I've been sort of thinking in that direction. The approval has just happened, so we weren't able to
Right.
extend it anyway beforehand.
Although NCCN allowed it 2
Yeah.
years beforehand,
I know,
right?
but not any insurers that I dealt with in
Right.
California. But I think that, the people who didn't have a PCR, the other way you could look at it is the pertuzumab wasn't helping enough. And so what can we do with the people who really didn't have a PCR? I'm not talking about like 2% cellularity left, but like people who still have multiple positive nodes, they probably need something else, a different type of treatment. So it's a little bit, and maybe that should be based whether they have ER-positive, ER-negative disease. It's hard to know.
But does the absolute benefit and affinity bother you?
Yeah,
The
but-
lack of benefit in ER-positive, does that bother you at all?
Sure.
Yeah.
So why are we doing it then?
Why don't you ask me
Right.
that question?
I'll ask Lee.
And then I'll think about it for a minute.
I'll let Kim think about it for a minute.
I do want to point out, everyone in Affinity got a year of pertuzumab. So I just want to be clear, because I think
They did.
some
But they-
people are...
They did
But
get
we
a
didn't
year-
select them.
No, I know that, and I'm just, this isn't, I'm
Right.
giving you time to think about why we're
Okay.
using pertuzumab and ER-positive, but
Right.
I think anything short of, I'm going to give 6 doses in the preoperative, and I'm not going to use it out back. But if you're going to take the affinity data and try to apply it to just every HER2-positive, they did get a year of the combination of
If you didn't have
pertuzumab and trastuzumab.
neoadjuvant data, correct.
Correct.
If someone's
Okay, I
in
just
the
wanna be
adjuvant
clear,
setting,
'cause
I have no problem with that.
I get a lot of questions about, like, do I just
Completely
give
agree with
6
that.
cycles in the adjuvant setting? And if you're going to use it in the
We
adjuvant
want to make
setting...
that clear.
yeah,
That's very clear for
okay.
the audience. It's really an important fact that if you don't have the neoadjuvant data, absolutely. Would we all kind of agree with that?
Well, but you have
If
to
you're gonna use
re-stratify
it.
patients.
Stratified, okay,
Right.
right. All right, so someone's in ER-negative, HER2-positive, and you're giving her, for whatever
And
reason,
big tumor.
adjuvant, a big tumor.
Right.
You're not giving her TH for whatever, 12
That's
weeks.
fairly clear. The data supports that there's more benefit
That's
in
really
that group.
important to say that to people, because
Right.
people I want to make sure people
Yeah,
have
I
that
agree.
take home from this. Right, but we're talking now about some in neoadjuvant setting, which is the vast majority of people we treat. They do not have residual disease. They had a PCR to 4 or 8 or 6 week cycles or whatever you give them. Are you going to continue the pertuzumab, and why? If you believe PCR is right.
Well, now, but
Why?
wait, we just talked about duration of trastuzumab. So does it work differently for the 2 anti-HER2 antibodies? Is a year better only for trastuzumab? We're putting a lot of faith in 4
Or it
cycles.
means the year
of-
is so good, the additional absolute benefit isn't enough to justify the additional 11 doses. That's kind of the way you know what I'm saying? That's what I'm looking at.
I mean, I think that's part of the issue that I have, is that if you've gotten a great benefit and you have PCR, we don't actually know if you took those patients and gave them 3 versus 9 months that it would make a difference,
Right.
because we've never studied that. So we're kind of, where we are with a year of trastuzumab, but it's a good time to question what the appropriate duration of pertuzumab is,
Right.
because the additional benefit is small except for in very high-risk disease. So maybe it doesn't, not necessary to give them an entire year of therapy. We just don't know the answer, because what was studied was a year of therapy.
Right,
That's right.
so we don't know the answer.
Yeah.
So
Right, but let
again,
me-
I tend to be the lumper of this
Yeah,
group,
that's
which
it.
is, if I'm going to make
So-
a decision to use pertuzumab, I tend to try to get it in for a
So a
year.
patient walks in the door, she has an ER-positive, strongly ER-positive, HER2 3+ tumor, 5-6 centimeters in diameter. You give her neoadjuvant TCHP or TAC THP. It's now the therapy's done. You send her to surgery. She's got, say she had 5.5 centimeters disease to begin with, now she has 3.
ER positive?
ER-positive, it's still ER-positive. You restain it, Kim, it's ER-positive, HER2-positive.
And her
What do you-
nodes are negative?
Let's say her nodes, let's say she has 1 node positive. Okay, what do you do? Do you
Oh.
give her additional pertuzumab?
I would, because, the subset
additional
analysis
pertuzumab?
of node positive showed
Right,
that
so there's
small
another
but
option, which
meaningful
is
benefit.
neratinib.
Right, which we'll get to in a sec. We're just going to
Right.
stick this on pertuzumab. We'll get the last 10 or 15 minutes. We're going to talk about neratinib. But for pertuzumab, would you give her pertuzumab?
I think when you're faced with a situation where you have not had full response and to a limited amount of therapy, yes, you should continue on.
And the one thing that would be nice to know, and again we don't, and so I think you're stuck with the trial as it was, is that in maybe that trastuzumab, proteasomab together plus endocrine therapy is better than trastuzumab plus endocrine therapy. So in a situation like that where I could start endocrine therapy, in addition, I could probably continue both antibodies.
But that was
like
true in Affinity too. I mean, everyone got endocrine therapy.
Everybody
They did, and they
endocrine
only had a
therapy.
very limited benefit, meaning
But
maybe what that means is
they
they did so
looked at
well, the additional benefit was not great.
ER-positive disease versus ER-negative, and then they looked at node-positive versus node-negative, but
Yeah,
not
ER-positive,
node-positive by ER and node-negative by ER, and that's a sub-analysis that I think is incredibly important, although the numbers are small, and because very few people recurred, the events are like impossible to assess.
Right.
So we need a little bit longer follow-up and information about that in order to really answer the question you're asking. So in node-positive, ER-positive disease, how much is the benefit of adding pertuzumab, and that we don't know.
I think that's a really important point. Remember, Affinity reported with only 3 years of median follow-up. And for the ER-positive
It's
patients,
going to take
may
5
not
to
be
10.
enough.
You're right,
It's
it's going to
good.
take 5 to 10.
Right.
I agree with
It
you.
is true that the hazard ratios for improvement with addition of trastuzumab at 3 years are the same as what they are at 8 years, you know?
Right.
So it's an interesting thing, even though you continue to see recurrences out to some period of time, not as long as HER2 negative ER positive disease, it appears. The ER negatives are all front loaded, right?
Right.
And so you really see a lot of the benefit in the first 5 years. So a little bit more follow-up for Affinity is going to give us a lot more information, I think.
No, I agree. So let's turn to the other addition, okay? You know, which further confuses the issue. We now have an erratinib, all right, a tyrosine kinase inhibitor. You know, now it was recently approved by the FDA for extended adjuvant therapy. Let's see. Hope, do you want to talk about XNET? You want to tell us, you know, the
XNET
trial?
is a fascinating trial because it, you know, I think it's probably the only trial of its sort with, you know, changing 3 companies, going from larger to smaller to, you know, shorter follow-up, well, longer follow-up, shorter follow-up to longer follow-up that resulted in drug approval. Actually, I think it's really intriguing, and I think that speaks to the power of the data. So XNET took patients who had no evidence of recurrent disease after a year of trastuzumab and randomized them to receive an additional year of neratinib or placebo. And as everybody knows what happened over the course of the trial, but now with longer follow-up, they've seen a persistent, very similar to what we saw with trastuzumab, that the early data is very similar to what the late data is. So even 2 years of follow-up, 3 years of follow-up, now more than 4 years of follow-up, that we're seeing really very similar separation between the curves between placebo and neratinib, with about a 2.5% difference in favoring neratinib for disease-free survival, but also almost a 2% difference in distant disease-free survival in the entire group. And then strikingly, in a pre-planned subset analysis, no difference in ER-negative disease, but a 4.5% difference in ER-positive disease. And then if you go back and do various things like you say, you know, did we treat you earlier after you stopped trastuzumab versus later? And did you have centrally confirmed HER2-positive disease, et cetera, you can even push up although those are all unplanned subset analyses, the benefit in the ER-positive group gets even higher. So I think that's a real phenomenon, and I think what scared us off from neratinib in the beginning and made the trials difficult to interpret in the metastatic setting is the high rate of diarrhea with, you know, in XNET, a 40% rate of grade 3 diarrhea.
And just so we know what grades of diarrhea, because we've all had to learn the grades of diarrhea, right?
8 or
So
more
grade 3 is 8 or
episodes.
more, and grade 2 I think is 2 or more, is that right? Or 3 or more? I always forget that. Grade 3, see, we got to remember what our grades of diarrhea are.
It's
Our
more than
fellows know it, but
2.
we don't. Anyway.
Yeah, 3 to 8.
Anyway, but
than
it's more than
2,
8
yeah.
stools a day is grade 3.
So grade 2, I think, goes 3 to
3 to 8.
3 to 8.
Yeah, 3 to 7.
3 to 7.
So in any case, you know, because this is a secretory diarrhea, I think to credit, you know, the neratinib makers, there's been a lot of emphasis on trying to make it more tolerable. And so the control trial looked at, you know, okay, you're giving, and the label says you got to give everybody. This is not a PRN like we do with pertuzumab. This is you got to take prophylactic antidiarrheal therapy up front the day you start. I always tell patients you should really start the day before you start your neratinib, and then you got to take it and the diarrhea with neratinib is early. It occurs within the first 2 to 4 weeks, and then it gets better over time. So because it's secretory and because people hate antidiarrheal therapy, it makes them constipated, the control trial looked at an oral non-absorbable steroid, budesonide, and also Colestipol.
And that was presented at San Antonio this
Yeah,
year.
and then updated, and we updated the data there. Colestipol, which is a bile salt binder. So, and it's really actually striking that patients tolerated incredibly well. I put a bunch of patients on control. None of them stopped. They were all happy, and mostly, and they didn't like coming in a lot for their study.
But they only got, the key to that trial, which is important, they only got 1 month of the therapy, the Colestipol and budesonide.
Right, and
That's it.
yeah.
And that was enough.
But that's that
to
first
keep them
month
going.
that's
It's
the
that
risk,
first
or the
month.
first 8 weeks.
And the
Right.
grade 3 went from 40% to a little under 11%.
Which is great.
With Colestipol. So it's a really big difference, and people like it. I've actually been using Colestipol for metastatic disease when I give
Does it work in
neratinib
metastatic
off-label.
setting as
Yeah,
well?
it works great. I mean,
Yeah.
they get constipated. You
That's
got to
great.
back
So
down.
I think we can
So-
get people over the toxicity now.
And you just
because
have to have
of it.
anticipatory guidance. You got to say, listen, there's going to be a month or two. We're going to really have to be intense about it. But after that, you're fine. So let's go back to that patient. I'm just curious because, we have all this data that suggests that, that maybe there's not as much benefit in ER-positive disease with proteasome, but there is with neratinib. So I'll present the case again. A woman comes in, 5.5 centimeter tumor, clinically node positive to make you feel better, Kim.
Yeah.
All right, clinically node positive.
Of course.
She basically gets whatever, 4 to 6 cycles, whatever we're going to give her, anthracycline, yes or no, gets HP with it, now has about 3 centimeters of disease left at surgery, and then 1 positive lymph node. Still ER positive, still HER2-3 plus. So the optimal therapy of that woman is what? Would you give her another year? We all, I think, are moving toward giving her proteasome, some. But the real issue is, do you give her neratinib after the year?
ER positive?
ER positive.
I would.
I certainly would.
I would too, and I think the big question we have that's come up with patients is how long do you give after the proteasome before you start the neratinib? Are you going to have worse diarrhea? But I have to say that with the control data and with the ease that people have of taking this medication, I feel a little bit more secure after proteasome giving neratinib and not worrying about it. And people said, we talked about it a lot at ESMO where the updated XNET trial data was presented. People said, well, you don't have the data giving neratinib after proteasome. And I'm like, well, but you do have data suggesting the benefit of proteasome is less in ER positive, and we've got really strong preclinical data supporting the use of a potent TKI in ER positive disease. So to me, it makes sense.
Yeah, I think the fact that they're complementary, that we see most of the benefit in pertuzumab in the ER-negative group and of neratinib in the ER-positive group, and the mechanisms of action are somewhat different, and mechanisms of resistance may be somewhat different through crosstalk between ER and HER2, for example.
So is there anybody you wouldn't do this? Say a woman has a PCR. Would you give her to her with PCR?
I would not.
No.
ER.
ER positive for PCR. So you give her whatever, she gets her PCR, you're going to give her the adjuvant pertuzumab. Some of us may not, but then it's a year later. Do you do it? Do you give her neratinib or not?
I would have that's a double negative. I would discuss it with
You
her.
would discuss it.
And I think that 4 to 5% absolute reduction in patients who did not receive pertuzumab but were ER positive, and the patient you're describing had residual, complete pathologic, but nodes positive at the beginning.
Okay.
I know the PCR means she's going to do great, but there is that population of women, and even in the 5-year mark.
That's a 10%
Yep.
recurrence rate.
And
Not
so
in PCR patients who are ER positive.
PCR patients are very positive. What's the recurrence rate?
Very low. I mean,
It's, well,
extremely
Pro-
low.
even if
in
it's
iSpy, it was under 5%.
Yeah, no, it's under
That's low.
2%. I mean,
Under
it's
2%.
tiny.
So again, what
But
are we
we have
doing for that
3 years,
absolute
not 5
benefit?
years.
What are we
So
doing for that?
she's node positive to begin with, though.
Right, but I think that we don't know that your stage at starting treatment
Right.
impacts your risk, except for maybe TNBC with a lot of cancer because they get more brain mets. But I think that, we don't know that that impacts your risk of recurrence after a PCR, because it may be because we missed some subclone or there was some, we just don't understand why some people relapse, but it's a very small number.
Right.
Yeah, I don't know. I've taken probably a more practical approach, which is I discuss it with all of my HER2-positive patients.
Right.
And I think that's an important message, which is
Absolutely
the last
agree.
thing you want is a patient coming back 6 months after they finish their Herceptin, or even worse, because we now know that neratinib, at least in my practice, seeing some of the retrospective unplanned analysis, the women who started within a year appeared to have a greater benefit.
Right, that was the
Unplanned
next question I was going to
analysis.
ask. We have a lot of people that come in and go, it's 2 years later.
Yeah.
Should I get it? And I
Right.
think
No.
Should they?
No.
No.
Probably
No.
not, but
So I'm sorry, didn't mean to.
So,
interrupt,
but
yeah.
I think you're obligated to discuss it. And you can say you've had a PCR and you're ER positive and you've paid your year of dues to trastuzumab or trastuzumab plus pertuzumab. There is this other drug that's been studied and it helps between 2 to 4 out of 100 women. Maybe not just like you, but at least when they took women who hadn't had pertuzumab and had ER-positive breast cancer and hadn't had preoperative therapy and all of those things. And it helps 2 to 4. We do this every day in our practice, right? Do you
Yes,
want
but those
taxane?
patients,
Do you
there's a
not
lot
want
of degrees of
taxane?
freedom there. So the patient's
Yeah.
going to then say to you, but Dr. Blackwell,
I know.
what would you do?
Right, if it were you, what would you do? You know,
I would try the neratinib, but I'm a little biased.
Well, now we have cholesterol
I'm a
and
breast
budesonide, so
cancer
that's
doctor, and what
Right.
I do all
Right.
day is see patients whose cancers come back that
Right, I
weren't
know.
supposed to come
We
back.
may be more risk
So
averse.
do you think there'd be any biomarkers for this? I mean, there's this. I saw this. I kind of was not to insult the trial, not that impressed with it. That stuff with PI3 kinase that was done at San
Yeah. I
thought
Antonio, was that a biomarker?
I
mean,
think
it's
there's
kinda
a hint
right.
there that
A
maybe
hint.
Yeah.
maybe the PI3
Believe
kinase
it?
mutations, and they included amplifications.
Yeah. Right.
Somehow there's this
How often is
interface
there
with
an
ER
How often are
positive.
PI3
It
kinase
was-
amplified?
it was about
Is that-
5 or
is-
10%,
really?
I think.
I never heard of that.
No,
Yeah.
it's more than that in
Really?
ER positive, HER2 positive
Yes.
disease.
So just for people to know, we're
Amplification?
talking
No,
about
no, just
we're talking about an
PI3 kinase
unplanned.
All
amplification,
alterations.
like 20%?
Yeah, for all alterations.
33 out of 593 patients.
Right, and
That's not very
593, you got it right
with
there. Just so
amplification.
people know, people need to know what we're
5%.
talking about. We're talking about a correlative analysis of XNET where they looked at PI3 kinase, not only mutations, but amplification as a potential biomarker for DFS. That's what we're talking about.
And there's been a hint before that a PI3 alteration
Correct.
impacts at least trastuzumab's benefit. as
Right,
well.
and remember those trials and we kind of
Yeah.
everybody said, yeah, they're hypothesis generating, but I'm not going to use it in clinical practice.
But if you looked at all the PI3 kinase alterations, it was more. You're just talking about the amplified, right?
Yeah, 33 out of 593 or
the
28 out of
amplified is much
608.
less
Not a
common.
lot.
But,
Right.
you know,
It's not a
it's
lot.
an interesting suggestion. I mean, we saw lots of things with trastuzumab, right? MYC, this and that and everything. We were going to be able to predict this. And, the only thing so far that I know of that's really helpful for us is knowing that a patient is HER2 enriched and we don't do it. So if you're HER2 enriched, maybe you just need to have a whiff of therapy near you.
Yeah, I would like to do a trial with the HER2 enriched with no chemotherapy
Yeah,
and
just
just
use
anti-HER2
Adjuvant, yeah.
therapy.
Just what anti-HER2 therapy would you use? Would you use neratinib? Would you use traz or both or neither?
I'd like to study both.
Really?
Yeah.
It's a neat trial. Would you do that just for ER? So what kind of patients would you put on that sort of study? I'm curious.
That would be
Low risk of some sort or high
yeah,
risk?
Yeah, patients, I mean, in a community setting, we often see older patients where even the 12 weeks of Paclitaxel may be a little
It's too
difficult.
much, yeah.
Well, HP, remember, HP by itself in
Was
Neosphere
inferior.
was like a 15 or 17,
16,
19% response rate.
Right, it was
something like
17% PCR rate. That gets my
that. That's
attention.
1 in 8. That's
Yeah.
not bad. One in
Yeah,
6.
with
That's pretty good.
unselected other than
Right.
HER2 positivity.
And then
I
there's
agree.
also, the trial from the West German study group, right, looking at ER positive, HER2 positive disease, where they just gave them 4 doses of TDM1 and saw
Yeah,
a
DAPT
PCR
was
rate
very
of
impressive.
45%.
Right, the Germans,
Yeah.
the German.
Yeah, I
Which was, I
think
thought,
though we
really
should be a
interesting.
little careful because even though there was that response rate in
Right.
Neosphere, it was half the PCR rate as adding chemo. So
No, we
We should
agree.
never do that off trial.
Off trial. No, this
yeah,
is
no,
something.
I want to be clear because I think
Right.
there are patients where I have a predefined notion that they're not going to tolerate the chemo, and we do it and they do fine, and the patients who I think are going to do super
Have
well.
terrible
So
outcome.
I think we
Would
should be a little
you-
careful.
I
yeah.
totally
Well,
agree.
I agree with you, but would you, put it this way, so whatever you give them, neratinib, proteasome, whatever, would you, like right now, give someone HP up front, and if they have looks like a PCR after 4 to 6 cycles of it by MRI or whatever, would you stop, or would you give them chemo?
Outside of a clinical trial?
Yeah.
I probably wouldn't
I
give.
wouldn't either.
I
I'm-
wouldn't either.
I have an
Pertuzumab
idea that
traz.
somehow it's not just PCR, but it's the therapy we're giving. And I think that where we're going to end up with that is going to be using these ADCs, the antibody drug conjugates,
Right.
and that maybe it won't be TDM1 in the end, but it'll be some of the maybe the new ones that seem to be highly effective in trastuzumab-resistant disease, where you could give 4 doses and get PCR in 50% of patients. Maybe that will shorten the amount of therapy that we have. We don't know.
Right.
that's just a guess.
Yes, there's a number of new drugs being developed, ADCs for HER2
Which look
positive,
really
which are
promising.
very exciting.
Although I think ADCs, at least in the neoadjuvant setting so far, have been somewhat disappointing. I think we'd all agree with that.
And certainly,
Is it
comparing-
Catherine,
yeah,
the trial I'm
Catherine.
thinking of?
Yeah.
Certainly
it's a little
comparing to our
surprising.
optimal chemo antibody combination therapy, it was inferior, and really fairly dramatically inferior.
Yeah.
So.
Which is surprising because the German studies look pretty
Well,
good.
that was
That
ER
study.
positive patients, so it was really
Yeah.
a selected group. So.
Yeah. All right, I think that, we should move on to the questions so people have time to answer their questions. We have about 10 minutes left. And so let's go to some of the questions that we've received from the audience. And hopefully, if you're out there on the web listening to us, you can bring in questions as well. We'll try to answer them live. The first question we have is between Affinity and XNET, what is the optimal adjuvant or neoadjuvant care for HER2 positive early stage breast cancer? I think we've talked about that, but let's give a case. Let's give two cases. So a woman comes in the door, she's got a 1.8 centimeter ER positive, HER2 positive tumor and is clinically node negative. What would you treat her with? Let's say she's 62. What would you give her?
Well, we use the APT regimen a lot, which is Paclitaxel and
This is
trastuzumab
neoadjuvant. You give it
I'm
neoadjuvant.
giving
She comes in the door, you haven't done her surgery yet. Would you do surgery and give her APT?
No,
With
well, I mean,
TH?
a lot of times we do see those patients after surgery, but if somebody came in the door with that treatment, I would say, well, if we give you neoadjuvant therapy, we might have a better idea of how much treatment you actually need. And, it's the same whether you give it pre or post, so we might as well give it pre, and I can start your treatment a little sooner.
So TH or THP?
Well, that's the question. I think prior to this we gave TH, but with the addition of proteasomab, it's just hard to know. I mean, if I was going to give it, I would only give it preoperatively. I think in somebody who has a T1C stage 1 tumor, I would feel comfortable with TH, ER positive.
So neoadjuvant TH times 12 and see where you are.
THP, I would talk to the patient.
If she was clinically node negative and she came in basically saying, I'm going to have a lumpectomy, and she could have a lumpectomy, meaning it's easy, she has a generous sized breast, I think you could go either way. You could either give Paclitaxel for 12 weeks plus Traz, because she would have been eligible for APT. She's less than 3 centimeters, she's ER positive. I think you could incorporate pertuzumab, or I think you could take her straight to surgery, and then at least you have the nodal information, which sometimes does guide our use, and sometimes it's uncommon, but we're usually pretty good with our imagers to know what the nodes look like. But I've been surprised. There's been, once a month we see the case of someone who went to the OR that we thought was clinically node negative,
Yes.
especially ER positive. And they have 7, 3 millimeter positive lymph nodes, and
Of course,
so
then I wish I gave them neoadjuvant therapy.
That's right.
I
I don't think,
know.
I agree with Hope and Kim. I think either Paclitaxel with trastuzumab or Paclitaxel, trastuzumab, pertuzumab makes sense for neoadjuvant if you're going to give. But typically in the adjuvant setting, I will use the APT, for a T1 and 0 patient.
See, and I think the interesting thing, kind of weirdly, the Affinity trial has made me more likely for these smaller tumors to do surgery up front. And if they're node negative, to give them APT, the TH.
Right.
If they're node positive, to give them TCH or TCHP,
I agree.
for the whole time. That's kind of just weirdly made me go the other way.
Yeah, I think the pendulum's in the middle now. I mean, there was a time where I was going around to the surgeons, every HER2 positive breast cancer patient needs to come and get preoperative therapy, and
Right.
now we're kind of back to the, let us see them, but not every patient
Right.
absolutely has to
Right, it's
receive
weird
their
to kick them
therapy.
back. I mean, I remember, I don't know what happens in your guys' groups, but every patient who was HER2 positive, I don't care how big the tumor could have been, 6 millimeters, I get a consult from the surgeon,
That's what I'm still getting, but
Still
I kick
getting
them
this, yeah.
back when they're
it's
small.
okay, especially
No,
if it-
keep referring
Yeah.
to us, surgeons, please. Don't
Yes.
stop referring.
Yeah, and I just
So-
want to make one point. I think for me, the decision-making about pertuzumab is a little separate than neratinib, mainly because it gets confusing to me.
Yeah.
And so it's not like at the time I'm seeing the patient from the beginning, I'm like, okay, I'm going to do either or I do think that the neratinib decision probably needs to be pushed down the road a little bit.
You don't have to decide up front. I
Yeah,
agree.
and I think
Yeah, I
some
think that's
people
true.
are a little, not confused, but I've been getting a lot of questions and calls about, do I
Doing it
need to
now.
decide right now? I
Right.
think if the patient would have been eligible for pertuzumab in the preoperative setting, or you interpret the affinity data as, I'm going to give this patient pertuzumab, I think you should follow that, and then, again, have a discussion at the end, or a discussion somewhere along. I think it does get a little too much for both me as the physician and the patient to try to juggle all those things at the beginning.
So I don't talk about CDK4/6 inhibitor adjuvant trials until I get there.
Right,
Because
correct.
otherwise they're just like.
That's right.
It's too much information. So let me do another few questions that are kind of interesting here. Right now, we talked a little bit about SOLD and some of the other trials. Are there any patients who could receive a shorter duration right now in your practice of adjuvant TRAS?
So I have one that I started last week that I'm comfortable giving it with the shared decision making that we said this is not standard of care.
So what kind of tumor?
And this is the 56-year-old with a 5 millimeter ER-positive grade 2 Ki-67 16% HER2-positive tumor.
Okay. All right. Do you agree? You guys agree with that?
I give it for a year
give it for a year,
unless
fine.
there's a toxicity.
But I think if it's a really tiny tumor and we know that the outcome is good, but the toxicity of treatment is small, I've been having this conversation with a number of colleagues recently that it might be worthwhile to treat, but then having somebody have to come in every 3 weeks for the rest of the year is probably a very, very little additional benefit. So I think that that decision is quite reasonable for these tiny, tiny tumors where we don't feel comfortable not treating them.
So I just want to make one more point, just to counter
Go ahead. No, we have time. We
Kim,
have 5 more minutes. So
is that there is some toxicity from combined therapy and for a year of therapy. It's
There
very
is.
small, but
Oh,
it would be
no.
hard to argue that the benefit of a year of Herceptin, absolute benefit in a patient like that, would be more than 1%. And we do know there's a 1% increased incidence of heart problems.
no,
So it's a risk-benefit thing. That's how I look at it.
So
I'm just keeping
But I think
it
that's
simple.
the only group of patients. And then I think the other thing which you mentioned earlier, which is really important, is that if you have a patient who drops their ejection fraction, rather than trying to get them
Right, you're
back on
done.
again
You're
and,
done.
Right.
That just
and
gives us
worrying
comfort that
about
you're done.
causing more and more
Right. I
cardiac
agree with
drugs,
that
you
one.
should put them on cardiac drugs, but you don't have to restart the trastuzumab.
That makes
So-
us very
So
comfortable.
that gets us another question. I'm really curious because I want to hear this because Lee gave a good case. That kind of patient, when is the patient you do a PAM50, she's luminal A?
So that's the kind of patient that I would love to have a trial where we do PAM, and we're getting ready to do this, to be doing intrinsic, and then seeing if this is a really not a HER2-enriched patient, if this is a luminal A patient, I mean, really, what do they need here? We don't know the answer to that.
Hormone therapy
but
alone,
Yeah,
probably.
probably,
Theoretically.
but maybe a short course of
You agree?
just HER2 therapy.
It may be, and I don't know, because we don't know that even the HER2 therapy is all that helpful in a
Right.
luminal A HER2-positive patient. And the neoadjuvant data and the CLGB40601 PAMELA trial, et
Yeah.
cetera, all suggest that the benefits are quite limited in patients of luminal A. Luminal B a little bit, but it's HER2
And luminal B, I
enriched
wouldn't go
primarily.
that far. I think
Basal.
luminal A, I think.
Basal doesn't seem to have much benefit.
Right.
So
Yeah, but just to be clear, we
This is
were
a
only
research.
going to do that in the setting of a
This is a
clinical
research
trial.
Absolutely,
I
only in
just
a clinical
Don't
want
trial.
to
do
be
it.
clear for this audience that if a patient's had a subtyping and they're not HER2 enriched.
you shouldn't use
Just
it
so you know,
for
Dr.
clinical
Blackwell and I have been
decision-making.
having this argument for 40
For-
years.
yeah.
It'll
No,
never end.
I agree completely.
It's a-
The
Yeah, I
standard
just-
is chemo and
But I will
trastuzumab
tell
minimum.
you,
Even with a 1% CHF benefit. So wouldn't you feel terrible? Someone with a luminal A tumor, you gave her congestive heart failure
No,
from
because we
HP?
don't
Yes.
know that data well enough yet.
True.
So I
I'm just being
agree with
provocative.
Kim
I'm not
here.
saying
Yeah,
it's
but
right.
we feel
I feel-
terrible if we harmed any patient.
Yeah, I feel
so-
terrible for
Right.
the women who still have neuropathy, which is not insignificant as well.
From their
So-
Paclitaxel, right?
Right.
I get it.
Or low hair.
So low hair.
hair.
So I want to add one. We're about to wrap up. I don't know if there are more questions. There's one here that I think Hope could answer for us, since she has been the PI of the trial of this. Is there anything in the pipeline to replace Herceptin? i.e. biosimilars,
Well,
i.e.
so
sub-Q
there-
Herceptin.
So there's several things, right? So there's a lot of new agents and there's new antibodies. I don't think those are ever going to replace trastuzumab, right? We have ADCs we talked about. We have a different sort of an antibody margetuximab, which is in a phase 3 trial. We have additional agents that are being added in. But for trastuzumab itself, which is here to stay and made a huge difference, the idea is that as this drug goes off patent worldwide, that we may be able to use alternative agents called biosimilars. There's now a biosimilar approved in the EU where the patent expired actually a little while ago for trastuzumab, and there's a biosimilar approved in the United States where the patent will expire next
2019,
year. For trastuzumab. And the data on these studies, which has been done in the neoadjuvant or first-line metastatic setting, is very, very encouraging. No additional toxicity signals, identical efficacy, and they're all trials that are really designed to show that response rates are similar. and they are. So I'm very secure in the using biosimilars, and we're already using them, of course, for growth factors, and they're using them in the rheumatologic field across the board, and there really haven't been any even case reports of difficulties.
Right. So I think that's something that's really coming down the pike, and I think we're all really...
And the advantage is cost savings and competition.
Right. And there's, to counter that, there's now the sub-Q preparations, which are available in Europe, but not yet in the U.S.
But maybe never in the U.S., because, somebody at a drug that's going off patent, the question is, could you reformulate it to give it sub-Q, and then that will be a whole other area.
Right. So we have two questions from the audience, in addition to the ones we just answered. The first one is, if the mechanism of action for neratinib is different than monoclonal antibodies like trastuzumab and not cross-resistant, why not give both in someone who you think needs both?
Well, funny thing, my colleague is just doing that study. So, we actually are opening a study soon, which is looking at giving neratinib while you're still on trastuzumab. And then we actually allowed, figuring that affinity would be positive and eventually proteasome would be available, because we started before affinity was even presented. We can actually do the triplet, but it may be that the neratinib dose will have to be, dialed back quite a lot. When you're not giving with chemotherapy, you may be able to do that. It would be great if you could give the neratinib and be done sooner, but the only thing we don't know is if the duration is important.
Right. Agree. Comments?
No, I totally agree. I mean, if we don't know for sure that the mechanism of action is non-cross resistant, but the data we have that we're extrapolating from the clinical data suggests that they're different and that we can use both.
Yeah, but I think there might be something, again, now that we saw that data in San Antonio, that the neratinib, if it started within a year of finishing the trastuzumab, that's important, that timing. You don't want to be off of it. I think what we saw with extended adjuvant endocrine therapy, I think it's not just the non-cross resistant. I think there's also
overlap.
Yeah, and there's some duration issue. So
maybe overlap with endocrine therapy for that extra year is really important.
Might be
Yeah, that could be.
something.
Yeah.
So the next question is, would you recommend neratinib in the adjuvant setting to a patient, say, with an ER-positive, 2-centimeter tumor, node-negative, ER-positive, HER2-positive, node-negative, with lymphovascular invasion? Kim?
Yes, and I would actually have a strong discussion with that patient, even if they didn't have lymphovascular invasion. So,
Fair enough.
Again, I think it's sometimes tempting to get into the weeds of if you have blonde hair and blue eyes, and which would be me. I'm going to
Funny
do
you
it
should
this
say
way.
that.
So funny you should say that, right?
Yeah, but the reality is the study was an intent to treat analysis of patients that had HER2 overexpressing tumors, and there were lymph node negative patients that were included, and there was a benefit, especially to the ER positive, HER2 positive patient. All of them were HER2 positive patients, so I'm not too keen on looking at all of the other, they're really great prognostic markers. I think I wouldn't be making treatment selections on individual prognostic markers.
That's interesting. I think I would discuss the neratinib with the patient, because I think it's a reasonable choice of therapy to give that patient. I'm a little influenced by what seems to be unbelievable outcome in the affinity trial in the control arm, that people just did really, really well with 3 years of median follow-up. And, we saw the benefit of neratinib quite early. I think that, ER-positive disease is relatively unique. And so, the ER-positive disease where you have the relatively lower ratio, where we know the benefit of trastuzumab is a little less, that's an even more of a situation where I would be even more encouraged to use neratinib in a stage 1 tumor like this with a bigger size.
I think the point is we don't understand the biology all that well yet. And so I think, going back to Kim's point, that if we look at the parent trial, we see the benefit across the board in the entire group, as well as the entire group of ER-positive, HER2-positive, whether they're lymph node negative or positives.
And so that brings us to the last question, which is, what do you think the optimal patient for neratinib would be? Optimal. Lee, you want to start with that one?
Yeah, well, I think there in the adjuvant setting, if we have a patient who's node positive and or larger tumor that's at higher risk of recurrence, which we know over the long time, after a year of their antibody therapy, whatever that is, those patients should go as soon as possible onto neratinib for a year.
Okay.
I
Agreement?
agree. ER-positive, node-positive, and then node-negative higher risk disease. So again, keeping in mind that patients do really, really well with HER2-positive disease who have small tumors in particular. Everybody does pretty well. So what we're trying to do is make the pretty well patients do better. And so that's why I would choose patients who have a clinically higher risk.
Yeah, I don't have much to add.
Yeah, I agree. Okay. So anyway, I think this has really, guys, been an excellent discussion. I hope you, the audience, have found this information to be valuable to your clinical practice, and we welcome your feedback on what we've covered here today. Please send us your suggestions to onclivenn@onclive.com, and thank you for watching the Onc Live News Network.